Cutting Edge with Anita is underwritten by Boomer Times and Senior Life, a lifestyle magazine targeted to baby boomers and seniors residing in the South Florida area. For information, go online to babyboomers-seniors.com.
Well, welcome to the show, everyone. We have a fascinating guest with a fascinating subject. Dr. Stuart Isaacson, who is a neurologist at the Parkinson's Disease and Movement Disorders Center of Boca Raton. And I've been sitting here and talking with him. Of course, I'm Anita Finley. And we've been talking about Parkinson's disease, of course, with Michael J. Fox coming on with his new show. It's just really brought it out to the forefront. But thank you, Dr. I was going to say Dr. Parkinson's. That's probably what's going to happen. You're so involved in it. Dr. Isaacson, for being here and doing this. And it seems like it's funny to say to someone, a physician, you're so enthusiastic about Parkinson's. I do that in the best sense of the term, that you're seeing so much progress in maybe the technologies and the medication to help Parkinson's disease people.
Well, I think that's true. I'm delighted to be here because we are enthusiastic about all these new treatments that are coming down the pike, and the real hope that with the new science and the new laboratory studies, we're going to have a cure for this problem in the next 5 or so years. I
was just sharing with Dr. Isaacson that maybe it was just I was out of the loop, but I never thought much about Parkinson's other than I was at one of the senior centers 5 or 6 years ago, and they had a Parkinson's support group there, and the people would go shuffling in, and I figured it was Parkinson's, either tremors in your hands or shuffling, but it's a bigger issue.
Yes, Parkinson's disease causes not only tremor but slower movements, a feeling of stiffness, a lower voice, sometimes some saliva overnight on the pillow, trouble getting out of a chair and out of a car. And all these problems with mobility reflect this loss of a chemical called dopamine in the brain. And when one has a low dopamine, the tremors and the slowness and the stiffness emerge. And the important message is simply that it may not be aging or getting older, but this loss of dopamine that we aim to try to evaluate and detect sooner rather than later.
Why can't we just take a dopamine pill?
In a sense, we do. In the late 1960s, in New York City and elsewhere, the identification of a drug called L-Dopa became almost a miracle drug because the body converts it naturally into dopamine. And really, the treatment of Parkinson's disease aims on earlier detection of the loss of dopamine and then of replacing it with L-Dopa and drugs like it.
And so, what are you now trying to find as a neurologist? What would be the holy grail? What would you really like to see that we can cure Parkinson's disease?
Yeah, well, our long-term goals have always been trying to detect the disease as early as possible and find some treatment to stop its progression or ultimately to reverse the loss of dopamine brain cells in the brain or restore them, either with stem cells or some other chemical that can cause these brain cells to regenerate and make their own dopamine. But until they make their own dopamine, we're lucky to have a dozen or more medicines to try to restore dopamine, and they tend to work for 15, 20 or more years, aiming to keep people with good motor function and able to live their lives fully.
And when someone is taking dopamine, does it affect other things, their memory, or is it just like taking a vitamin pill?
Yeah, well, unfortunately, dopamine can cause side effects in some people. Now, most people don't have side effects, but some people can get a little queasy or a little sleepy initially, but this tends to almost always go away with time. More recently, we've found other side effects like compulsive disorders and hallucinations, but these are much less common, and typically when one medicine causes that, we can use other medicines that don't.
Okay, well, let's start off and just tell us what actually is Parkinson's disease.
So Parkinson's disease was first identified
by Dr. Parkinson,
by
right?
Dr. James Parkinson.
I hope that's true.
A English physician who identified a couple of patients that he made the real recognition was not normal aging, but really something else, because they all sort of had a little bit too much stoop posture and a little bit too much slowness and lack of spontaneous movement. And Later, about 100 years later, people identified a chemical called dopamine, which is related to adrenaline that we feel in our body. And adrenaline and dopamine are very similar, but dopamine works to help movement. And this loss of dopamine was found to be in the part of the brain that is involved in Parkinson's. So when people began to give L-Dopa, the symptoms became much, much better. And even today, that's the real cornerstone of our treatment, using L-Dopa that becomes dopamine, medicines that mimic dopamine. We have medicines that go to the brain and prevent the breakdown of dopamine. And we have all sorts of new injections and patches and infusions coming that can mimic dopamine more consistently.
So if someone comes to you, makes an appointment because they're a little nervous about what they're feeling, maybe they have Parkinson's, maybe they have something else, how do you test them so that you can say, yes, you have Parkinson's disease?
Well, traditionally, we've looked at the examination and the history, asking questions about whether the golf drive is shorter or veers off to one side, or whether the jogging has become slower, or maybe just getting in out of a chair or the couch, or getting out of a chair at the movies. We also look for things...
Wait, what would happen there if you're doing it more slowly?
So if you get more difficulty getting out of a soft chair, having to sort of rock back and forth before you can get up, if you've had a loss of balance once you're standing, some people notice trouble getting out of a car, swinging their legs around. So all these things that can be confused with things like arthritis and older age and just the general aging may instead reflect this loss of dopamine and be the very earliest signs of Parkinson's. So when we detect things like this, we look at the handwriting, because the handwriting can become smaller, the voice can become lower, there can be some saliva overnight on the pillow. And then we do an examination looking for the tremor and seeing the mobility of the arms and the legs, whether they're slower with foot taps and finger taps. We examine the muscles and look for signs of what's called stiffness or rigidity. We examine how one gets out of a chair and walks down the hallway, whether there's a loss of arm swing and a stoop posture. And more recently in Europe, they've had for about over a dozen years a new brain scan that can detect the loss of dopamine. And about 2 years ago, this brain scan was approved by the FDA, and this is called DAT scan. And the DAT scan can detect at a very early clinical stage this loss of dopamine in the brain, and this can be very helpful in people where the diagnosis is not secured yet.
Amazing. Well, you certainly are an exciting field, and I was asking Dr. Isaacson, what made him get involved with Parkinson's specifically, because as a neurologist, you have an opportunity for a lot of things, don't you?
Yes, the neurologists do treat the entire nervous system, all sorts of brain diseases and muscle and nerve diseases. And this number of diseases that seem to occur with aging, and in the aging so-called boomer population, like Alzheimer's and Parkinson's, have become increasingly common, especially down here in South Florida, where it's been so important to try to get the awareness out and education to try to identify and diagnose these types of disorders sooner and get treatments for both of them sooner.
Yeah, that's great. I was just, and it's a little bit, maybe it's off the subject, but ALS, that's a neurological disease.
Right.
And what is the problem? What's the difference in that? Is that dopamine also?
No. So ALS, or Lou Gehrig's disease, involves a problem with the part of the brain that controls strength, and also the brain cells in the spinal cord that control movement of muscles. It's a much less common disorder, but devastating. And ALS can really, in many people, cause very big problems within a year or two, if not 3. Alzheimer's, more in the range of 5 or 7 years.
And
Parkinson's, really, people have pretty good response to medicine for 15, 20 or more years. So we really have identified that a lot of our patients from up in New York and throughout the North and East and Midwest really were still doing okay. They just moved to Florida, so we've lost track of them. And we've been able to reconnect with them down here and continue the treatment.
That is, and we were talking a little bit about heredity. And why don't you explain that?
Yeah, this is really such a dramatic finding. A couple of years ago, a gene was identified in Ashkenazi Jews. These are Jewish heritage people who came from Eastern Europe, Russia, Poland, Germany, Romania, a lot of these countries, and really wandered and throughout and made it over here to South Florida and throughout the country. But really, South Florida has the third largest concentration of Jews from Eastern European heritage. So this gene is incredibly important down here. And it turns out that this gene called LRRK2, we don't really know what it does. It seems to be involved in how dopamine may be released, but it seems to maybe account for somewhere around 25% of the patients who are Jewish and have Parkinson's disease. So with the help of the Michael J. Fox Foundation, we have spearheaded a very large project down here looking to find patients who have Parkinson's disease who are Jewish, and indeed people who don't have Parkinson's, who are normal, but had a father or a mother or a relative with Parkinson's disease, to come in and see a genetic counselor and be tested for the gene, so that we can try to identify some biomarker, some marker in the blood or the urine or the new brain scan, the DAT scan, so we can try to find this and diagnose this early, and then find new ways of slowing the progression for future generations. So it really is an important project.
It's great. Oh, it's so wonderful that you're here with us. I just want to introduce you again to Dr. Stuart Isaacson, who is a neurologist at the Parkinson's Disease and Movement Disorders Center of Boca Raton. I'm Anita Finley, and of course you're listening to Cutting Edge with Anita. And I was thinking, as you were saying, of course we know as one grows older, it seems a lot of the diseases become apparent, but what is the youngest age? I mean, how young was Michael Fox when he first discovered this?
Well, Michael Fox writes in his book, Lucky Man, that he was 31 when he was first diagnosed. And sometimes Parkinson's can begin with a tremor in one hand or a foot, but sometimes it begins with a cramping of a foot or a hand. It's called a dystonia. And this can cause the foot to turn in when one is jogging or just overnight in the middle of the night. It's a little different than a muscle cramp, but somewhat similar too. Or the hand to curl in and such. And this type of early cramping or dystonic cramping of a foot or a hand can sometimes be an early symptom of Parkinson's. And he writes how he had to go from doctor to doctor to try to diagnose it, because very often with Parkinson's disease, as well as with Alzheimer's disease, the diagnosis can be delayed for a year on average, as one tries to confirm the symptoms and try to see if there's any testing that can be useful in diagnosing it. And then even after diagnosis, it often takes another year to begin treatment, as one tries to make sure they really have this disease. And it's why it's so important that we identify some type of test in the blood or the brain, in addition to this brain scan, to really confirm the diagnosis of the loss of dopamine and begin treatment sooner.
And as you're talking, I remember people have asked me about restless leg syndrome. And it's making me think, I'm wondering if that has anything to do with what you're talking about.
So that's an excellent point. Restless leg syndrome is due to some problem with dopamine, but not a loss of dopamine. Indeed, the dopamine levels are normal. We know this from the DAT scan, for instance. So if one has symptoms that can be confused in the legs between restless leg syndrome, which typically occurs as one is lying down at night and trying to sleep, and the legs have this urge to move, and moving them make them feel better, we use actually the same drugs we use in Parkinson's, but for a different reason. But if that can be confused with Parkinson's, the DAT scan can tell them apart. Whereas the DAT scan would be normal in restless leg syndrome, it's abnormal and shows the loss of dopamine in Parkinson's.
So much to know. And you certainly are really on the cutting edge, as I said. It's amazing. So what are we, what's then on the, well, let's just talk about a couple of things you mentioned to me before we were on the air, and I love this, the whole thing that Medtronic is doing with the insertion, that's very exciting in the brain.
So while the medicines we have often work quite well for the first 5 or 10 years, after 10 or 15 years, each dose of L-Dopa, which comes in medicines like Sinemet, may not last 5 hours anymore, but may last 3 hours or 2.5 hours, requiring us to give them more frequently throughout the day and to combine them with other medicines to make them last longer. In some people, we still cannot be successful in getting the medicines more consistent, and while we await new therapies, the brain stimulator can be inserted. A little hole is drilled in the skull, and the wire is placed through the brain and connected to a pacemaker-like device in the chest, and then done on the other side. And this can help restore the consistency of the mobility that L-Dopa is still giving, but is very inconsistent. In Europe, that's one therapy, but there's two others. In the United States, that's the only advanced therapy when people can no longer take the medications effectively. In Europe, we also have different types of infusions. One is called duodopa, and this is a form of L-dopa that goes directly into the stomach through what's similar to a feeding tube. And this was before the FDA and will likely be approved sometime in mid-2014. And the third therapy is much more exciting. This is a little subcutaneous patch-like catheter that goes on every day and infuses, like the insulin pump, a medicine throughout the day, and then at night you take it off. It's a tiny little pump that goes in the pocket. And this type of medicine called apomorphine or Apogo pump is coming to the United States in a pilot trial we're doing down here in Boca Raton, and then in Detroit will be the second site in December. And this will allow people who either cannot have the surgery because they have trouble with the memory or fear the side effects of having the brain surgery to really restore their mobility by just putting this little pump on every day.
I'm sitting here with my mouth open. This is wonderful stuff. You must be so thrilled. It seems like it's all coming very quickly, isn't it?
Yeah, well, I think the FDA has recognized the severe unmet needs in this disease state. I think people like Michael Fox and Muhammad Ali, who have come forward, Pope John Paul II also had Parkinson's disease, and having people come out and really say, I have this and we need to get better treatments for it has been very important to not only encourage the FDA, but also the companies that come out with these products and make these new drugs and invest the money in trying to determine if they work. We're involved in 15 or 20 clinical research trials right now just on Parkinson's disease and Alzheimer's disease and restless leg syndrome, and trying to find new treatments, but these come from companies that are trying to find new treatments as well.
Let's talk a little bit about your office then. So if people want to be able to contact you, what number would they call you at your office to set up an appointment?
Oh, they could call, it's 561-392 1818 and
I'm sure you must, let's see, it's
561-392
1818. And what is you have a website?
The website would be www.parkinsonscenter.org.
Okay, parkinsonscenter.org.
Yeah. And if they're interested in that gene evaluations, there's actually a special email that they can email, or anyone could really use, called PD Gene Study at parkinsonscenter.org. But any of those ways can get you into the loop. If someone want to get information about new research, or come in and talk to one of the research coordinators, find out about the genetic testing with the genetic counselors, or just try to see if they can see myself or one of the colleagues and confirm or evaluate Parkinson's disease or the need for the DAT scan. All of these things are available. There are also some social workers and support groups and speech and physical therapists and such.
And so, are you looking for people for your trials?
Well, it's so important.
Clinical trials?
It's so important. Michael J. Fox's foundation and their website has what's called PD Trial Finder. And this Trial Finder allows people to really find out about trials throughout the country and to register anonymously, to be contacted about future trials. The truth of the matter is that while we're studying around the world 50-odd medicines, and down here about 20 medicines, it takes several years to have enough people go into a trial to find out if it works and let it move on to the FDA's evaluation. And if we could somehow quicken this, and if people wanted to try these medicines and see if they can help, if they work, you get the ability to get the medicine for free for several years before it's approved. And we have drugs that are coming to market now that a lot of our patients have taken for 3 or 4 years already and didn't have to wait so long for the new treatments. And also trying to be involved in trying to find better treatments or a cure for something that you have and that in some may be passed on through the generations, can be very satisfying to know that you're empowered and able to take charge and find new treatments and be part of these programs.
I was just going to say that, yes, it really is a way for you to help science, and research. Yeah. I'm very involved with the Scripps Research Institute up in Florida, and I know that, up in Jupiter. And I know that they're working very hard. Who are you working with up there?
Well,
I forgot his name.
Yeah, well, One of the laboratories up there with Dr. Locascio, he's working on the same gene, the LRRK2 gene, that we're looking to identify patients who may have the gene and ways of following them and detecting them. And there are drug companies around the world, and in his laboratory as well, who have identified small molecules that may help treat this gene problem specifically. So it really requires a multi-concerted effort to have patients who are tested and then followed over time, and drug companies that seek to take laboratory findings and bring them to market and study them, and then patients who are involved in this process as well.
Now I want to just get to the humanity part of this with Parkinson. So someone is, someone is has Parkinson's, and they go out, and they're trying to look like everybody else, and they're shaking and they're walking. It must be hard on them to feel like everybody else, and people stare at them and they feel embarrassed. How do you handle this with them?
Well, I think two ways. I think that one way is to have a very good support system, whether it's family or friends or social workers or support groups. Daily exercise is so important, we've discovered, not just for mental health, but actually for physical health. I was just up at the World Parkinson's Congress in Montreal, and there are a number of scientific presentations demonstrating the value of all sorts of exercises, from dancing to Tai Chi to yoga to riding a bicycle to walking. But any type of physical exercise done daily is so important, not just for the general benefits we think about with exercise, but studies have demonstrated, one of my colleagues in the laboratory in UCLA has demonstrated, that just general exercise makes the brain make more dopamine. It makes the dopamine brain cells work better and work harder to make more dopamine. So I think there's lots of benefits. So one is just being healthy, eating healthy, exercising regularly. But the other thing for people to know if they do have Parkinson's or care for a loved one with Parkinson's is that any symptom of Parkinson's reflects ultimately too little dopamine. And perhaps better treatment, using some of the more modern treatments that have come to be available in the last few years, may help to restore mobility and lessen the tremor and improve the walking and the balance. And some of these symptoms that we take as being part of Parkinson's really are part of not getting the best treatment for Parkinson's in many patients. And better treatment can often improve these symptoms. And I would gather that most people with Parkinson's, you don't know they have Parkinson's. Much like Michael Fox was able to act for more than a decade with Parkinson's disease, and no one knew it until he's told people. So I think that lots of people have Parkinson's but have no symptoms apparent because they take their medicines, replace dopamine, and have such an improvement that it's not apparent to general observation.
I think the Parkinson's people down here have the surf and turf, and they're talking about swimming. This is what you were saying, and I didn't really, and I thought it was because it was just a matter of being together, but you're saying the exercise creates more dopamine.
Yes, so the loss of dopamine can be increased by medicines and by exercise, but the loss of dopamine causes not only movement problems, but it also impairs motivation and initiative. And dopamine is so involved in the addictive disorders. A lot of our knowledge of dopamine comes from the addiction laboratories and looking at things. Cocaine addiction. Cocaine actually influences dopamine specifically, but all the addictive disorders have a problem with dopamine and too much wanting to do something. So the loss of dopamine has sometimes caused a lack of motivation and initiative. So I tell patients that I see that it's not so much that you want to go up and exercise, but you have to do it anyway, even if you don't want to, because that's precisely the problem. The National Parkinson's Foundation has a wonderful chapter down here in South Palm Beach that sponsors for free a lot of these exercise programs, the surf and turf. And these types of programs people should make use of if they're not exercising on their own. Most people exercise on their own and find something they like to do. But if not, some of these classes can be very useful as well.
So was there a Dr. Dopamine? It's just of course, it's a name that now is becoming we can just say dopamine easily, but before it was like, what is dopamine? It's dope, we didn't really know what that is, but you're right. Yeah. So in essence, it sounds like there's a lot of promise in this. We're unlike, I know in Alzheimer's all of us are so concerned about that, but I hadn't really been concerned that I would ever get Parkinson's, but actually, because of what you told me, I guess my family heritage is what you said, but my mother didn't have it and my father didn't have it, but it's a potential then, is what you're saying.
So what we know from Tel Aviv University and Beth Israel in New York City, the two places that have really studied this gene that seems to be in people of Jewish heritage, is that if you don't have any family members with Parkinson's, it's a very low likelihood of having this gene, probably on the order of 1 or 2% in the Jewish population. But if you have a family member, then it may rise to about 12 or 15% chance that you have the gene. And if you have the gene, then there's only about a 30 or 40% chance that you'll develop Parkinson's disease, at least by the age of 60, although as one ages, the risk probably increases. At the beginning of this program, we've so far had about 150 people come in who had a father or mother with Parkinson's, but they did not. And only about 12 have this gene in that initial grouping who are interested in, and some who are interested in being followed very closely with the Michael Fox program.
Okay, so food. Let's talk about diet. We have about 4 minutes left. Oh, if someone has Parkinson's, are there special foods that would help them?
Not really. I think people with Parkinson's should have a normal diet. There are some who find out that eating too much protein around the time of taking Cinemet can interfere with the absorption of L-Dopa, and they have to then adjust their diet accordingly. But most people should have a normal, healthy diet. There really are no vitamins or supplements that have been shown to be useful. Neither CoQ10 nor vitamin E or vitamin C, which have been studied in large trials, have been found to be useful and probably not worth that money. I think the biggest thing is that if the diagnosis is not secure, the DAT scan can diagnose it and confirm it sooner.
And you have the DAT scan in your office?
So the DAT scan is both available at local places in Boca Raton as well as at Boca Regional Hospital. And there's also a website that can give people information about the DAT scan if they're in communities that don't have it. And that website is Move to Answers. That's the number 2, moveToAnswers.gehealthcare.com. Because GE is the company that brought this DAT scan to America after it's been in Europe for decades. So I think the combination of awareness and education with all the work that you do and the new modalities and brain imaging that can help diagnose it earlier, the recognition that symptoms reflect too little dopamine, so you have to use the new medicines to replace dopamine so the symptoms are really at bay and mobility is like normal. And the new things coming down the pike, these new research medicines, the infusions, the brain stimulator can all give us great hope that as we wait for a cure in the laboratories around the world and in the next, hopefully, 5 years or so, that we all have better treatments in the meantime.
This is great. And for those of you who like to have alcohol, be very careful, because if you have Parkinson's, I would think that you wouldn't want to do that. Is that we didn't cover that at all?
Well, too much alcohol is no good, but probably a glass of wine at night is fine.
But I was just thinking, because that's the one serious aspect that we didn't cover. When you have Parkinson's, you have to be careful about not falling.
You don't want to fall. That's a big goal.
Yeah, so people, and I always say this, if you need a walker, use it.
Yes.
Because once you fall and you break a hip and you have Parkinson's, I'm sure there's a lot of serious implications after that. So
Yes.
Go see Dr. Isaacson. It was great having you here. I can't thank you enough, and we certainly look forward to a lot more of your information, your special force down here.
Thank you so much for having me on and hoping to spread some education and awareness of Parkinson's disease.
We will. Thank you, and we'll be here next week, same time. Be sure to listen to my show every Saturday morning from 5 to 8 on WSBR, 740 a.m. Show, of course, 8:30 to 9 on 1470. Have a great week. Bye.